Thank you. So I'll be switching to English again, so you might have to bear with me a bit, but thank you so much for having me here, and I'm really excited to be talking a bit about the work I've been doing for the past 3 years. So I'm in my PhD right now, supervised by Dr. Martin, who you saw earlier, and I'm actually going to be speaking a bit about different cellular therapies for the treatment specifically of systemic sclerosis-related interstitial lung disease. So we've heard a bit about systemic sclerosis today, and we know that, of course, it's a systemic autoimmune disease, but what I really want to focus on, one aspect that to me is particularly interesting, is the interstitial lung disease. So this is present in about 40% of patients and is currently the leading cause of death in these patients. So, of course, it's incredibly important to fully understand and develop further therapeutics that we can use. So, in its deadliest form, interstitial lung disease can manifest as pulmonary fibrosis. So here what you can see is, as opposed to a healthy lung, we have this stiffening, the thickening of the lung interstitium, and that results in impaired gas exchange. As well, because this lung is so stiff and so laden with scar tissue, it becomes very non-compliant, very difficult to expand, so of course there's a difficulty to breathe for these patients. And currently, although there are 2 approved antifibrotic drugs, these don't actually reverse fibrosis. So, of course, this represents a very highly unmet medical need. And so for this reason, we were looking at the application of MSCs, mesenchymal stromal cells, as a potential therapeutic option. So, of course, you've had a very nice introduction to them already, but briefly I'll just mention that in vivo, these are cells that reside in the perivascular sites, and by definition, according to the International Society for Cellular Therapy, these are plastic adherent and can differentiate in vitro into adipocytes, chondrocytes, osteoblasts, as well as having specific cell surface markers. So just for the purpose of this presentation, all MSCs moving forward have been characterized by this definition. Now, why these are particularly interesting is that these cells are very adept at sensing and responding to their environment. So in a resting state, they're quite quiescent. However, when exposed to inflammatory molecules such as TNF-alpha or interferon gamma, they can become activated, expressing and secreting many anti-inflammatory and immunomodulatory factors to really maintain homeostasis. So that effect can actually be mimicked in vitro. So priming can be mimicked in vitro by stimulating with interferon gamma and TNF-alpha. And so that priming is known to have anti-inflammatory effects and tolerogenic effects, as in enhancing those abilities, those therapeutic abilities of MSCs, as well as pro-angiogenic. However, what's unknown is whether they really enhance the antifibrotic effects. And so that really hasn't been studied in an animal model of systemic sclerosis interstitial lung disease. So that's really what we set out to do here. So briefly, this is the model that we've been working with. It's a systemic sclerosis model. So for the purposes of this presentation, I'm only going to be showing the lungs, but it is just important to note that this also does have skin as well as kidney involvement. So what we do is we take Bleomycin, which is a fibrosis-causing chemotherapeutic agent. We put them in these little tiny mini pumps that continuously release the drug over 7 days. And then we remove that pump on day 7. So then we've sacrificed these mice at day 14, 21, and 28 to look at the fibrosis in the lungs. So the first thing we do is we look at the pulmonary function testing, which, as I mentioned, fibrotic lungs become very stiff and very thick, very difficult to expand. So that's the measure we're looking at here. These are our pressure volume curves. So you can see that this is our negative control or healthy control with PBS. But for a given pressure, at all time points that we studied, these are equally stiff. The volume doesn't increase as much. And you can see that here taken from the compliance. So the compliance is measured from the pressure volume curve. And you can see a significant reduction in compliance already at day 14 that's sustained over 28 days. Why that's particularly interesting to us is if we actually look at the histology there. This is our lung histology stained with picrocereus red stain, which stains collagen specifically. The top is bright field, the bottom is polarized light, which specifically refracts the collagen. The collagen specifically refracts the light, so we can quantify that rather objectively. What we actually see is that day 14, there really isn't much histological abnormality despite that early reduction in pulmonary compliance. So, keep that in your mind for later, but that was something that was particularly interesting to us. But by day 21 and day 28, we do have substantial collagen deposition in these lungs. So what we did in terms of investigating the use of primed MSCs in this model is that at day 7, we injected by the tail vein 500,000 MSCs, either resting or primed, and then we sacrificed the mice at day 21. We also included a positive control group, so that was nintedanib, which is a known and approved antifibrotic drug, as a positive control to really benchmark these findings. So what you'll see right away, this is oxygen saturation over time, so over the 21 days, and this is at the 21 days, the 21-day mark. So first you'll notice that there's a significant reduction from baseline with just the bleomycin treatment alone, as we would expect, about minus 30% in oxygen saturation. And that's significantly improved with the primed MSCs. This is our primed group here. Nintedanib as well as resting MSCs have no significant improvement at day 21 in oxygen saturation. So there's some promising effect already with the primed MSC group. This is protein concentration measured from the bronchoalveolar lavage fluid, so really taken from the alveolar compartment. And again, a similar story. You can see that there's a significant increase in total protein concentration in the alveolar compartment, which is indicative of vascular permeability. And neither the nintedanib or resting MSC group is actually able to significantly reduce that. However, the primed MSC group does significantly improve that vascular permeability. And a very similar story as well for the total cells in the bronchoalveolar lavage fluid, suggesting a significant reduction with the primed MSCs with regards to total inflammation in that compartment. However, where we actually don't see a difference is with the pulmonary function testing. So all of these groups, you can see bleomycin and all our treatment groups have very consistently lowered pulmonary function. So there is no improvement with that respect. We also did a micro CT from these mice, and you can just see visually, of course, there's less aerated tissue with the bleomycin compared to PBS. Nintedanib, resting MSCs, and primed MSCs as well all seem to have visually some improvement, especially in the primed group. And when we took the lung volume normalized to the body weight measured from that CT, you can see essentially a preservation of the lung volume with only the primed group. And that's really significant and significantly improved compared to just resting alone. So, that's really quite promising there. And then if you look at the whole lung histology, so this is our picroserous red of a whole lung slice, you can see again, the bleomycin, of course, you have these dense, fibrotic areas where there's a clear improvement, and that's quantified, that improvement, with picroserous red, with a reduction in all of the treatment groups, but also with collagen-1 mRNA. So there's a significant reduction with the primed group, even just compared to resting MSCs alone. So there seems to be a clear benefit. But one thing you will notice, as I showed at the beginning, is there seems to be this disconnect between what the histology indicates and what the pulmonary function indicates. So, as I said, at day 14, there's that reduction in pulmonary compliance that doesn't match up to what is a seemingly normal histology. And you can see here again, the histology seems to be quite normal, quite healthy, but the pulmonary function is equally compared. So I won't have time to really get into that today, but essentially it led us to look at pulmonary surfactant. And what we found was that the pulmonary surfactant was severely impaired in this model. And it really was this accumulation of dysfunctional surfactant. So we looked at the uptake system, being the alveolar macrophages, to see, why there's this big accumulation of dysfunctional impaired surfactant. And so if we just look at the macrophages as is in this model, these are the alveolar macrophages stained with oil red, and we have this massive population of these oil red or lipid-laden macrophages. So these are macrophages that essentially are non-phagocytic, and we've done other characterization, but these are filled with lipids and not able to either phagocytose as well as break down the lipids that they actually have ingested from the alveolar compartment. So because of this, we decided to administer bone marrow-derived macrophages. So we took these macrophages we took stem cells from the bone marrow, treated them with MCSF as well as GM-CSF. And the GM-CSF not only makes them more alveolar-like, because that's the environment that they would have developed in naturally, but also it kind of kickstarts the phagocytosis a bit, and it really enhances their phagocytic abilities. And so I administered 1 million of those cells directly into the lungs at day 7 and sacrificed at day 28. And so what you'll notice first off, which is really amazing, is that for the first time, there's a complete restoration of the pulmonary function. So you can see there's a very clear overlap between the PBS group as well as the bleomycin mice that received the macrophages compared to just the bleomycin alone, and that's also reflected from the static compliance as well. And then really remarkably, when we look at the whole lung histology, this is on H&E, you can see very, very clean, nice histology with a very minimal affected area just from these macrophages alone. And that's reflected by quantifying the percent diseased area, so very significant reduction in diseased area, quantified by picroserous red pixels, as well as hydroxyproline, which is the gold standard for quantifying fibrosis. So seemingly very effective and very promising. So ultimately, this model does allow for the assessment of the antifibrotic effects in lungs, and it does seem that a single dose of primed MSCs is superior to a single dose of resting MSCs at improving oxygen saturation, reducing vascular permeability, and inflammation, as well as collagen in the lungs. However, this doesn't really improve the pulmonary function. So administering these GM-CSF pre-treated bone marrow-derived macrophages did result in improved histology as well as improved pulmonary function. So of course we need to move forward and really look into the mechanisms, but yeah, thank you so much. So I'd just like to thank my supervisors and of course Dominique Farge for inviting me here. So thank you so much.